Good afternoon, one and all. My name is Dr. Saranya. I am Senior Resident of Department of ENT from Sri LAKSHMI Institute of Medical Sciences. Today we are going to see about CSOM, that is chronic suppurative otitis media. CSOM is defined as the chronic infection and inflammation of the mucosal lining of the middle ear cleft. What is meant by middle ear cleft? Middle ear cleft includes opening of the eustachian tube orifice in middle ear cavity plus mesotympana, atic, Otitis and antrum. So, the infection of the middle ear cleft which leads to repeated episodes of ear discharge along with the perforation of the tympanic membrane is defined as CSOM. So, in order to say it as a chronic suppurative otitis media, the duration of the disease process should be more than at least 3 weeks to 3 months. So, the middle ear cleft includes eustachian. Once again, the middle ear cleft includes eustachian tube orifice, mesotympana, Otitis and mastoid antrum. So, there are two types of CSOM. One is Tubotympanic disease, also called as safe disease or mucosal type of disease. Next is aticoantral disease or squamosal disease or unsafe ear. Today we are going to see about the safe type or Tubotympanic type of CSOM. So, what is meant by Tubotympanic type? Tubotympanic type mainly involves the anteroinferior part of the middle ear cleft. Anteroinferior part includes the eustachian tube orifice and anteroinferior part of the mesotympanic. Whereas aticoantral disease mainly involves the atic. It is a disease of atic. Atic means epitympana. The part of the middle ear cavity which is lying above the tympanic annulus is called atic, and Otitis and mastoid antrum. So, the aticoantral disease mainly involves the pathology of cholesteatoma formation. Cholesteatoma is nothing but a cystic bag-like structure which contains the squamous epithelium. Usually, middle ear cavity is nowhere lined by squamous epithelium. It is lined only by columnar respiratory type of epithelium, that is columnar cuboidal-like epithelium. But the squamous epithelium is lined mainly in the external aortic canal, and in the pavement-like epithelium is present over the mastoid antrum. Anywhere the migration of the epithelium into the middle ear cavity leads to the formation of cholesteatoma. So, cholesteatoma is a cystic bag-like structure which contains central keratin, and it is surrounded by desquamated epithelial cells with fibrous tissue. This cholesteatoma formation leads to the destruction of the ossicles, and with the release of enzymes it can lead to the formation of granulation formation, and the disease process can erodes into the nearby structures, and it can lead to intracranial complications also. So, these processes are involved mainly in case of aticoantral disease, whereas a tubotympanic disease is a safe type of disease. So, mainly the disease is from ascending infection from the eustachian tube. So, it involves only the anteroinferior part, and it can be easily managed medically. If it is resistant to medical management, then we can go for surgery. So, tubotympanic is a safe ear, and it does not cause any serious complications. The infection is limited to the anteroinferior part of the middle ear cleft, and it is associated with the central perforation. Central perforation means a perforation present in the pars tensa, and the margins of the perforation are surrounded by intact pars tensa. So, why is tubotympanic disease is safe? There is no risk of any bone erosion because cholesteatoma is not present in tubotympanic type. There is no risk of any bone erosion, not known to cause any intracranial complication, and the discharge from the middle ear flows freely through the perforation of the pars tensa into the external auditory canal, and usually the perforation of the pars tensa is surrounded by intact rim of pars tensa, and the annulus is intact in all cases. Fibrous annulus or tympanic annulus is nothing but the peripheral condensation of the pars tensa, which is usually preserved in case of the tubotympanic disease. Whereas in aticoantral disease, the perforation or retraction pocket is mainly present in the atic, that is pars flaccida or posterior margin of the pars tensa. Posterior margin, it involves one part of pars tensa, the other part, the fibrous annulus or tympanic annulus, is destroyed. Hence, if it is destroyed, the squamous epithelium from the canal can easily migrate into the middle ear and can cause the complications of cholesteatoma formation. So, the difference between the CSOM, tubotympanic and aticoantral disease are: tubotympanic is a safe, aticoantral is unsafe. Tubotympanic mainly involves the anteroinferior part of the middle ear cleft, whereas aticoantral disease mainly involves a posterior posterior part, that is Otitis and antrum. Here the perforation is usually central perforation in tubotympanic. Central perforation means a perforation which is present in pars tensa and the surrounding margins of the perforation are surrounded by pars tensa, whereas in aticoantral the perforation is present in pars flaccida or in the posterior superior margin, where one part is lined by pars tensa, the margin of the other perforation is lined by the tympanic sulcus. The fibrous annulus is destroyed, and discharge is usually scanty, copious, that is more copious, and mucoid or mucopurulent discharge in type of tubotympanic, where it is scanty and purulent and foul smelling and bloodstain in case of aticoantral disease. Why it is mucoid in case of tubotympanic is because the medullary cavity is lined by columnar or cuboidal respiratory type of epithelium which contains mainly goblet cells. So the secretions are usually more viscous and it is produced in copious amount. Whereas in aticoantral disease it is purulent, means it is mainly from the squamous epithelium. And so in aticoantral the pavement-like epithelium where the wear discharge is mainly produced because of the cholesteatoma leading into chronic irritation and inflammation, and the air discharge is usually scanty and foul smelling. And the hearing loss can be conductive in both the sides if there is any involvement or any toxins which destroys the inner ear can lead to mixed type of hearing loss. And the polyp is present in both types, but the polyp means inflamed edematous medullary mucosa which is collapsing through the perforation, and the polyp is usually pale and it is not bleeding in case of tubotympanic, where it is very reddy, fleshy and friable and does bleed in case of aticoantral disease. And granulation, osteitis, bone erosions which are more common, and complications, intracranial complications are more common in aticoantral and it is very less common in case of tubotympanic disease. Today we are going to see mainly about the safe type or tubotympanic type of disease in CSOM. So what are the etiological factors of chronic suppurative otitis media or inadequately treated acute otitis media and ASOM becoming into a permanent perforation? And what is meant by permanent perforation means the margins of the perforation does not heal because it is lined by the squamous epithelium, so it is very difficult to heal. And ascending infections of the eustachian tube, mainly eustachian tube opens into nasopharynx, and any infections of the nose and nasopharynx can also lead to the infection of the medullary cleft. The common nasal infections in children are adenoiditis, adenotonsillitis, etc. And in case of adults, it can be because of deviated nasal septum with acute rhinosinusitis and also allergic rhinosinusitis. And then the third cause can be the traumatic central perforation. If infected secondary, can also lead to chronic suppurative otitis media. So, what are the organisms causing CSO? Gram-negative bacilli are more common positive organisms isolated from the medullary mucosa. The common organisms, aerobic organisms are Pseudomonas aeruginosa, E. coli, Klebsiella, and Bacillus proteus, and anaerobes are Peptococcus, Streptococci, Bacteroides species. These organisms are usually not present in the respiratory tract. These organisms are commonly present in the skin of external aortic canal. So, what are the clinical features of CSOM? As I said earlier, the discharge is profuse and mucoid. Mucoid means that is present, it is secreted by the epithelium of columnar cells, hence it is mucoid. And if it is infected secondarily with anaerobic organisms, it can lead to mucopurulent discharge. It is not foul smelling. Whereas in cholesteatoma, it is foul smelling, that is fishy odor because of the granulation, osteitis and bone destruction. And the infected area is open at both the ends, hence discharge doesn't accumulate in the medullary cavity. The medullary cavity is directly opened into the canal by a big pars tensa perforation, so discharge can easily come out through the external auditory canal. And the ossicular chain is usually not involved in case of tubotympanic disease. Only there is a perforation present and can cause mild to moderate deafness of about 30 to 40 decibel. And in case of cholesteatoma, it involves the bone destruction, mainly the ossicles. Lung process of incus is more commonly involved, and it can lead to ossicular necrosis and leads to the hearing loss of more than 35 to 40 or or CSOM in both sides. Pain is present only if the patient has two problems. One is associated otitis externa, that is, the patient has habit of repeated cleaning of the ear canal can lead to injury of the external outer canal skin and can lead to otitis externa. Next can be because of acute mastoiditis, one of the most common intertemporal complications of CSOM. The patient presents with severe pain over the mastoid region and there is a positive reservoir sign. And stages of tubotympanic disease. These are the four stages which are common to both trichoantral as well as tubotympanic disease. Active stage means the disease process is active. The patient will be having a perforation along with a ear discharge, which is of duration of more than 3 to 4 months. And the patient should be actively discharging at the time of examination. Inactive stage means only perforation is present, only the perforation of the pars tensa is present and discharge is not present. If in order to say it is inactive or dry, the patient should have a dry ear or discharge should not be active for more than 3 months. Depending upon these two conditions, the therapeutic procedure differs. For inactive stages, we can directly go for meningoplasty, and active, we have to control it through the medications, or we have to rule out the septic fascia, or we can go directly into cortical mastoidectomy. Quiescent stage means intermittently discharging it. That is, for 2 months it might be discharging, it might be absent for 3 months, and once again it might be discharged. The disease process is not stopped, it is intermittently discharging. Healed is, it is the final resolution stage. Sometimes it can heal on its own. The disease process has been eradicated. If in case of small perforation, it can heal on its own with a thin atrophic scar. Active stage, as I said earlier, air is actively discharging. The middle ear mucosa is not normal. It is maybe edematous, hypertrophic, and sometimes it can be a polypoidal and it can prolapse through the perforation. And the discharge is mucopurulent and it is not pulse-smelling. Inactive stage, there is only perforation of pars tensa, annulus fibrous unless it is intact, but middle ear mucosa there is no active inflammation at present, so it is normal and healthy. Quiescent stage is the perforation of the pars tensa. The middle ear is usually dry, or it can be, when it is inactive, it can be dry. When it is active, it can become hypertrophic like that. So the patient might be having discharge at the time of the examination. Sometimes it can be absent. Healed stage is the healing of the trunk by a thin scar. Sometimes there can be something called as tympanosclerotic patches might be seen. Tympanosclerotic patches are nothing but the hyalinization, condensation of the tympanic membrane, which becomes thickened to form some white patch over the pars tensa. This tympanosclerotic patch usually can cause a mild amount of hearing loss also. But tubotympanic, the ossicle continuity is usually normal. Next, we are going to see about the next test which we are going to perform on the patient. We will perform the tuning fork test. First test is called Rene's test. Rene's test is usually done to find out what is the hearing loss which the patient is having, whether the patient is having normal hearing or conductive hearing loss. Here, the tuning fork is striped and is kept, vibrating tuning fork is kept over the mastoid process, and the patient is asked to raise the hand when the vibration stops, and it is brought near the external auditory canal, and air conduction is compared with that of the bone conduction. Usually, in case of a normal person or sensory neural hearing loss patient, air conduction is more than the bone conduction, which means it is Rene's positive. But in cases of CSOM, the common hearing loss will be conductive hearing loss. So here, bone conduction is more than air conduction. That is, the patient will hear vibrations over the mastoid rather than the sound kept tuning fork kept near the external auditory canal. So this is inferred as Rene's negative. Rene's negative means bone conduction is more than air conduction, which implies the patient is having conductive hearing loss. And then we'll do next test, which is the most specific and sensitive test, which is called as Weber's test. Here, vibrating tuning fork is placed over the midline prominence. It can be placed over the vertex, forehead, glabella, root of the nose, or in the upper central incisor. Here, vibrations of bone conduction is mainly tested. That is, whether the patient is able to perceive the vibrations on the skull both sides. Usually, if the patient is having normal hearing on both sides, Weber's test is centralized. but it can be lateralized if the patient is having unilateral hearing loss. In case of conductive hearing loss, the Weber's test is lateralized towards the ear which is having conductive hearing loss, that is towards the negative side. If it is negative on both sides, then is negative on both sides, then the Weber's test is lateralized towards the ear which is having more conductive hearing loss. That is, if one ear is having 30 and one ear is having 50, Weber's test usually lateralized to the ear with 50 decibel of hearing loss. Next, if the patient is having sensory neural, say if the patient is having right side sensory neural hearing loss and left side is normal, Finney's test will be positive on both sides. But when we are doing Weber's test, it will be lateralized towards the better ear, that is opposite ear. He is having right side sensory neural hearing loss, then Weber's test will be lateralized towards the left side because of the transcranial transmission of the sound. Next, in order to, if Rennes is positive on both sides and Weber's lateralized to the left side, we have to identify which ear is having sensory neural loss. For that, we are doing something called as ABC, that is absolute bone conduction, which is a test for bone conduction. Here, we will keep the vibrating tuning probe of the mastoid on the mastoid process and we will occlude the tragus. And we will check the bone conduction of the patient with that of the examiner, provided the examiner's hearing should be normal. If the patient and the examiner hears of the same duration, then it is normal. ABC is not reduced. If examiner hears for a longer duration than the patient, then it means that his bone conduction is reduced, which indicates that the patient is having some sort of sensory neural hearing loss. Next, we will be proceeding to the investigations for audiological investigations for hearing. Pure tone audiometry is a subjective audiological test which will confirm the presence of the hearing loss and what is the type, degree, how much airborne gap is present, and whether there is any associated mixed loss also. Usually, in conductive hearing loss, it affects air conduction. Bone conduction curve is usually normal. So, bone conduction curve will be within 10 decibel. Air conduction will be affected and there might be of 30 to 40 decibel hearing loss. And the gap between the bone conduction curve and the air conduction curve is called as airborne gap, which can be up to 10 to 15 decibel in order to see it as a conductive hearing loss. So, it can be also sensory neural hearing loss, especially if it is associated any other pathology like polysteatoma eroding the inner ear, or if the patient has used ototoxic agents like gentamicin, eardrops and all, there can be release of toxins into the inner ear which can easily damage the cochlea and can lead to sensory neural hearing loss. And if in case of conductive hearing loss, if it exceeds more than 60 decibel, then we should think that ossicular chain disruption can also be present. And conservative management. What are the next management of CSOM? First, we can, for safe disease is usually a disease process infection is limited to anterior inferior part. So, with antibiotic and correcting the septic foci of infection, we can easily manage the CSOM. So, but in articular disease, since the infection is mainly a disease process involving eroding and it is can lead to many intracranial and intratemporal complications, we have to manage it only by surgical means with the removal of polysteatoma. But in Tubotympanic, we can first opt for medical management and eradication of the septic foci, and then later, if it's not possible, we can directly go for surgical management. Conservative management includes oral toileting or irrigation, suction clearance, and dry mopping of the discharge. Main role is to keep the ear dry. In order to control the discharge, we have to keep the ear dry. We should ask the patient to take precautions to keep the ear dry, avoid unnecessary swimming, hair bathing, and keep a flat while traveling outside in cold weather, etc. These are the common precautions we should do. And if there are associated any epithelial debris present, we can clean with mild syringing with 1.5% acetic acid. Orthotopical antibiotic eardrops can, along with Dexa, that is steroids, can also be given to control any inflammation or polyp present. Mainly Ciplox, Dexa, or Aflox with Dexa eardrops or neomycin and eardrops can be given. And oral antibiotics in case of active discharge after culture sensitivity can also be given. Along with that, we can give analgesic, anti-inflammatory and antihistaminics if there is associated sinus pathologies also. So, systemic drugs, antibiotics, antihistaminics like levocetirizine and cetirizine, etc. can be given. Ototoxic eardrops should be avoided, especially gentamicin, like that should be avoided. If the patient is having any acute nasal infection with rhinitis, a short course of nasal decongestion can be provided, but it should not be used for longer duration because of the risk for rhinitis medicamentosa. And the same precaution which I told you previously, that is the ear should be kept dry. Pre-existing any sinus infections or adenotonsillitis should be treated either medically or surgically, and focal sepsis should be evaluated carefully. And next, if the medical management, if you are not properly managing, we can go for surgical management. Prior to surgical management, we should roll out the septic foci in nose. If the child or patient is having adenotonsillitis, it should be looked up for, and adenotonsillectomy can be done. And if there is deviated nasal septum with chronic rhinosinusitis, the patient should go for SMA or septoplasty with functional endoscopic sinus surgery. If there is any allergic polyp or any nasal mass, it should be evaluated carefully, and excision or polypectomy with functional endoscopic sinus surgery should be done. And the next is surgical management. If the disease process is even after clearing or treating the focal sepsis, or it is resistant to antibiotics, next we can go for surgical management. The goal of the surgery is towards eradication of the focal sepsis, as I mentioned earlier, and also towards the eradication of the disease process in the middle ear disease, which is called as mastodectomy. Mastodectomy means the disease process involving the mastoidectomy is cleared, and it is also aimed towards a reconstruction of the middle ear conduction mechanism. That is, the loss of the hearing loss which has occurred due to the perforation or ossicular discontinuity can also be repaired, which is called as lingoplasty and tympanoplasty. Along with that, we have to clear the diseased mastoid abscess, that is called as mastoidectomy. What is tympanoplasty? Tympanoplasty is nothing but defined as the surgical procedure which enables the reconstruction of the middle ear cavity along with ossicular system. It also involves the reconstruction of perforated eardrum. So, tympanoplasty means repair of tympanic membrane along with ossicles. So, only the repair of tympanic membrane is called as laryngoplasty. Only repair of ossicles is called as ossiculoplasty. Repair of tympanic membrane along with ossicles is called as tympanoplasty. Ossiculoplasty is used to reconstruct the damaged ossicles of middle ear cavity. As I said, lung process of fingers is usually found to be commonly eroded, especially in cases of polysteatoma or middle ear polyp, etc. And here in ossiculoplasty, we will do type 3 tympanoplasty mainly, and the diseased ossicle especially can be removed, and it is replaced with prosthesis which is TORP or PORP, which is partial or total ossicular replacement procedure. You can also use autograft, that is cartilage which can be reshaped, and it can also be used for reconstruction of ossicles. Aims of tympanoplasty is mainly towards the eradication of the disease, restoration of ventilation. There is mainly infection because of ventilation problem. That is, the middle ear cavity is not well aerated because of the infections of the eustachian tube. So we have to restore and ventilate the middle ear cavity along with the mastoid. The tympanoplasty is also aimed to restore the middle ear ventilation also, and repair the ossicles and tympanic membrane, and the creation of self-cleansing dry cavity. What are the preoperative investigations we should do before going for surgery? First is tubal function test to check about the function of the eustachian, whether it is functioning normally or if there is any eustachian tube dysfunction prior to surgery. Otherwise, even after surgery, the eustachian tube function is very severe. This dysfunction has been severe, then it can once again lead to same pathology and reperforation. And audiometrical evaluation for pre and post-operative comparison and documentation, and radiological investigations of X-ray mastoid and higher resolution CT temporal bone to check for the disease process, involvement of the ossicles, hematization status of the mastoid antrum also can be checked, and all the investigations, hemoglobin, complete blood count, X-ray chest, RFT, blood sugars, ECG, everything can be done for anesthetic fitness in case if you are operating under general anesthesia. And what are the common graft materials which are used for reconstruction of the tympanic membrane or temporalis fascia, dura, cartilage, perichondrium, periosteum, even split skin graft, fat from the lobule. These all things can be used for tympanic membrane grafting. Commonly used graft is temporalis fascia. Why it is preferred than the other? Because it has a low basal metabolic rate and the thickness of the tympanic membrane is similar to that of the eardrum. That is, it is of about 0.15 millimeter and it can be harvested through the same incision. While operating, we will put a post-oral incision that is called as William Well's incision for mastodectomy, which can be extended superiorly and we can harvest the temporalis graft from the same incision also. And there is no hurt of harvesting. It is plenty. We can even for revision surgery also we can take temporalis fascia graft, and it has the compliance is very good and it has a good uptake rate compared to that of the other grafts. In case of cartilage, we can harvest it from the tracheal cartilage or conchal cartilage, and but its thickness is compared to it is very much thick compared to that of fascia, and there is incidence of hearing which is hampered post-operatively. Thank you. To summarize, CSOM is the infection of the medullary cleft which involves eustachian tube, mesotympanum, Otitis and antrum. There are two types which are Tubotympanic and antrum. Here it involves the antero-inferior part and there it involves the posterior-superior part. Antero-inferior part of the medullary cleft is associated with the perforation of the pars tensa, which is called as central perforation, whereas in antrum it is attic perforation or marginal perforation. That is unsafe because of the presence of cholesteatum, which can lead to disease process, which can cause destruction of the surrounding bones and also intracranial complications. So, what are the common causative organisms are Klebsiella, E. coli, Pseudomonas, and anaerobes like Streptococci, Streptococci. It is mainly because of the ascending infections from the eustachian tube and also because of pre-existing acute otitis media or acute suppurative otitis media. And then hearing loss and perforation are the main characteristic clinical features. Other things like polyp, granulations, etc. can also be seen, and we have to manage the patient medically, and all the investigations should be done. Oral swab for culture and sensitivity, endoscopic examination, examination of the ear with microscope can also be done to identify which part of pars tensa is involved, whether the perforation is large or small, whether it is involving 1, 2 or 3 quadrants can be also be visualized. And then we have to do audiological investigations like pure tone audiometry preoperatively to evaluate and compare the hearing gain after postoperatively. And then we have to do all the tests for preoperative fitness. First, we have to try for medical management for tubotympanic disease, and we have to look for the sepsis foci which can be in the nose, that is adenoiditis, sinusitis. We have to clear that, and then we have to proceed for CSM. And other investigations of HRCT temporal bone, CT of paranasal sinus and X-rays can also be done. And endoscopic examination of nose and ear also should be done. If there is it is not beneficial, you can directly go for surgery. You can either do laryngoplasty for cases of inactive stages of tympanic disease. For active stages, we have to do mastodectomy with tympanoplasty. Tympanoplasty involves reconstruction of both the tympanic membrane as well as ossicles. Laryngoplasty means reconstruction of tympanic membrane alone. Ossiculoplasty means reconstruction of the ossicles. Long process of incus is most commonly involved in case of CSO. This can be reconstructed with prosthesis or with whole autocotyledons. And mastodectomy means it can be a cortical or a modified radical mastodectomy. A modified radical mastodectomy is the definitive procedure of choice for apical disease. Cortical mastodectomy or canal wall intact canal wall mastodectomy is the surgery of choice for tubotympanic disease. Here, the disease is eradicated from the eradication of the diseased mastoid air cells and antrum with intact canal wall. Canal wall is should not be removed; it should be kept intact, and then the reconstruction of the middle ear with tympanic membrane is done. And the precautions should also be given to the patient. You should keep ear dry, should avoid upper respiratory tract infection, and should also avoid water toxicity